Okay, Andrew, will you let us know when we're live?
Hey everyone, we're live.
Mr. Chairman, take it away.
All right, well, welcome everyone to the Springtime 2021 Health Policy Commission Board meeting. We have a very full agenda, so I'm going to turn it over to our Executive Director, David Sells, to give us a lay of the land and to move us forward. David?
Good afternoon. Thank you, Chair Altman. As you said, a full agenda today, so we're going to get really right in it. First, we have just a couple of housekeeping items to take care of and an important consideration of the Health Policy Commission's Vice Chair. So, Chair Altman, if you'd like to lead us through
Yes, I'll be glad to. First of all, we have the minutes of the January 13th meeting. Do I have a motion to approve the minutes?
So moved.
All right. Are there any additions, corrections? If not, we need to have a roll call vote. And so I'm going to ask my able assistant, Colleen, to read your names and we will vote. Colleen?
I'm happy to do so, starting with you, Chair Altman.
I approve.
Commissioner Cohen?
Aye.
Commissioner Berwick?
Aye.
Commissioner Blakeney?
Aye.
Commissioner Cutler?
Aye.
Commissioner Foley?
Aye.
Commissioner Haupt?
Aye.
Commissioner Kreider?
Yes.
Commissioner Mastergiovanni?
Aye.
Commissioner Roeder?
Aye.
And Undersecretary Peters.
Aye.
Thank you.
All right, that sounds like a unanimous approval. That's great. Our second agenda item is, I think all of you know that we are required by statute, but also in terms of our operating, to have a vice chair for the commission, and that the vice chair needs to be voted on by the full board. And I would like to recommend a continuation for the vice chair for Mr. Marty Cohen, who has led this organization during my temporary illness. And so I will accept a motion to approve the appointment of Martin Cohen as the vice chair.
Motion.
Okay, there's a motion. Do we need a roll call vote, Colleen?
We do.
Yes, well, then do your job.
I assume Vice Chair Cohen accepts this reappointment.
I'll beat him on the head if he doesn't.
Okay, great. I'll start with you, Chair Allman,
Oh, I approve.
and Vice Chair Cohen.
I'll abstain.
Okay. Commissioner Berwick?
Aye.
Commissioner Blakeney?
Aye.
Commissioner Cutler?
Aye.
Commissioner Foley?
Aye.
Commissioner Haupt?
Aye.
Commissioner Kreider?
Aye.
Commissioner Mastergiovanni?
Aye.
Commissioner Roeder?
Aye.
And Undersecretary Peters.
Aye.
Thank you.
Well, that's great. Well, welcome to the fold there, Marty.
Thank you, Stuart.
All right. Well, we're now going to move on to a very important, some would say the most important aspect of our activities, which is the approval of the benchmark for the following year. I'm going to in a moment turn it over to Colleen to take us through this effort. But I want to remind all of my fellow commissioners that the benchmark acts as our focus efforts in terms of how well the state is doing to dampen down on cost spending growth. As Colleen will explain, much of our activities are dictated by statute, but it is still a very important subject. So Colleen, you can go into more detail.
Absolutely. As you said, Mr. Chairman, very eloquently, the benchmark is a cornerstone of our activities at the Health Policy Commission. The HPC has an important responsibility to set the healthcare cost growth benchmark annually to advance the goals of transparency and accountability. The benchmark is really a long-term strategy or target for curbing healthcare cost growth and assessing the key trends and drivers of spending. It is not an annual cap on spending, and there have been years we've exceeded the benchmark, and there have been years we've been below the benchmark. But on average, importantly, Massachusetts has controlled spending below that target on average over the past 7 years. So today we're asking for a vote of the board to finalize and set the benchmark for the next calendar year or growth between calendar year 2021 and calendar year 2022. So for next year, 2022, it is prescribed by law that the benchmark will be set at the default rate of potential gross state product, or PGSP, which is 3.6%, minus a half percentage point, or 3.1% in this case. So 3.1% is the lowest growth rate allowed by law. The commission can elect today to vote to modify the benchmark up to any number between 3.1 and 3.6. If there is a modification to a number other than 3.1, it is subject to legislative review and additional processing. And in past years, the board has elected not to modify, remaining at the default rate of 3.1. So on this side, you'll see we are now in the last year of this middle period of the HPC having some limited authority to modify between 3.1 and 3.6, again with the default rate of 3.1. And then next year, when we set the benchmark for calendar year 2023, the HPC will have a much broader authority to set the benchmark, but that too will also be subject to a process of review. And then on the next slide, just details of the timeline of this process. The deadline to set the benchmark is tomorrow, April 15th, so we are right on time. A big part of this entire process is the public hearing that we held, a comment period in March, along with members of the state legislature's Joint Committee on Healthcare Financing. So we thank the members, the staff, and the committee chairs, John Lawn and Cindy Friedman, for co-hosting with us again this year. If the board votes to modify the benchmark today, we must submit notice of that intent back to the legislature, and there could be potential for further review by the Joint Committee of such a decision by the board. On the next slide, just a few key takeaways. We did receive testimony from a number of organizations, both orally at the hearing and in writing. Everything is posted to our website. The majority of organizations testifying at the hearing supported the 3.1 benchmark. Broad themes were concerns about inpatient, outpatient spending, pharmaceutical costs, delivery of care in high-cost settings, concerns about the continued impacts of COVID-19. These are all identified as key drivers of spending for us to watch. And some testifiers also noted concerns about health equity and applying a health equity lens to the benchmark. And then on the next slide, we show this every year. Finally, here's a summary of the testimony that we received from all the different organizations. I noted here whether they indicated a position about where the benchmark should be set. And it lists them all here for your review. And I'll leave this up for a second. And then on the next slide, we'll just leave you here with the motion to establish the benchmark. And I'll turn it back over to the chairman for the discussion.
You're on mute, Stuart.
Yeah, I am. I want to remind our fellow commissioners that we did have a lengthy discussion about the information and that we indicated concern. And I want to reemphasize that we have limited authority, as Colleen pointed out, between accepting the 3.1 or moving up to 3.5. But unfortunately, and I would emphasize, unfortunately, spending in the last couple of years has exceeded the benchmark. However, we should not take that to mean that the benchmark is not important, because even though we have exceeded the benchmark, we still are under the growth in spending for the rest of the country. And given the fact that before the existence of the Health Policy Commission, we were significantly above the rest of the country. So the benchmark has had, and I believe has had, and I hope many of you as well, an impact on slowing the growth. Nevertheless, the fact that we are exceeding the benchmark in the previous years is troubling. So with that said, I would welcome any comments or questions by fellow commissioners. Don, would you like to say something? I didn't know whether. Anybody?
Commissioner Foley and Commissioner Cutler both have their hands raised.
Okay, Commissioner Foley?
Thank you. I saw the list before about the testifiers, and it showed two, I think, hospital systems that raised objections to 3.1. I remember their testimony, excuse me, at the hearing about being concerned that they're being held to the same growth standard when they're a lower cost provider to other providers that are higher costs, and the impact of growth is different. Was that their objection, or did they put forward a goal or a benchmark other than the 3.1?
Well, let me answer that, and then maybe others, David, Seltz, or other staff members. First of all, I want to make it clear. The benchmark does not limit the growth in any one provider or insurer. It is an overall spending growth for the state. And what the two hospitals talked about, or one hospital, Lawrence General, was that they believe that they've been significantly negatively affected by growth in spending, which has been less, and therefore they would like to see their growth go higher. There's nothing by us putting in a 3.1 or 3 point, whatever the number is, that precludes them from going higher if they can get agreement from their payers. So their concern was their own institution, and that they believed that the existence of the benchmark limited them, but there's nothing in our activities or in the statute that requires any one unit within the state from going above or below, for that matter, the benchmark. Do I have that right there, David?
Very, very well put, Chair Altman. And I will just add an additional point, which is to say, as part of our process where we do review individual providers or health plans through the performance improvement plan process, as you all know, one of the factors that we review in determining whether a PIP would be warranted is the underlying price levels of those institutions. And so we do examine the underlying price variation in considering whether a PIP is warranted.
Thank you, David. David
Thanks.
Cutler, you have some comment?
Sorry, Stuart, that's very helpful.
Tim,
But
go ahead.
did they specify that they had another benchmark that they were suggesting that we move towards, or just objecting to setting it at 3.1, or did they have another number? Or
If I remember, the answer is no, they didn't.
okay,
But
thank you.
Colleen or David, did I?
That's correct. You're correct, Stuart.
Very good. And any follow-up to Tim? You're good. Okay. David
Thank
Cutler,
you.
please.
Thank you, Mr. Chairman. I wanted to make a couple of comments. One is I'm very much in favor of keeping the benchmark at 3.1%. Second, I think it's going to be a challenging year because we know that 2020 growth will be below 2019, at least based on everything we've seen. And some of what happens in 2021 is then going to depend upon issues like, or I guess 2022 is going to depend on issues like what happens with recovery from the pandemic, what happens to deferred utilization, and so on. So all of those are going to have to factor in, and we'll have to pay attention to them. But I also think, in light of what we've seen the past couple of years, I think we're probably going to have to take action this year with respect to performance improvements plans, because I think that I think that market participants are concluding that there's not much of a consequence to going above the cap, which I think the state had not intended that people to have that impression. And so I support the target, but I also think we will need to do more than that. And I'm looking forward to our discussions of that as they come up.
I think, David, thank you so much. I think it's, it's very unfortunate and it's unavoidable that the information that was presented last time stopped in 2019. And so I'm so glad you brought up 2020. As we will see in the coming slides that the staff will present, 2020, the COVID year, was rather strange to say the least. And even though we've come back up to the baseline, overall there was somewhat of a reduction in spending. And therefore 2022 is going to be an abnormal year as those providers who can try to make up for it. But I appreciate your comments, David, that our benchmark issue itself is going to be severely tested in the months and even years ahead. So thank you for bringing that up. Marty Cohen, you had your hand up?
Yeah, so just three points as well on the benchmark. First of all, I want to acknowledge everyone who provided oral or written testimony. The testimony was compelling, and I think offered a real assessment of the pressures and challenges faced by our state's healthcare delivery system, especially now as it relates to COVID. I too will be voting to maintain the benchmark at 3.1%. And keeping in mind that it is a growth target. I was struck by the testimony of Deb Wilson at Lawrence General and Kim Holland at Signature. And it almost seemed to me that they were looking for a differential benchmark, which of course we don't have in our legislative mandate the ability to do. But lastly, I want to agree with Professor Cutler. I think setting of the benchmark is one tool in our toolbox, but we need to look at those other tools, particularly the performance improvement plans, and we may need to dig deeper in those instances where payers or providers are exceeding the benchmark and seek some real plans for addressing those situations. The timing may be difficult given the circumstances relative to COVID, but I think going back and taking a hard look at those cases where the benchmark is exceeded needs to happen nevertheless.
Ron?
Thank you, Mr. Chairman. I would like to agree with my colleagues. I also support the 3.1% benchmark, but I think it's really important that we spend more time on performance improvement plans and probably need to get in certain areas a little more aggressive with that. And I think that's going to be a key to our success in terms of trying to maintain the growth rate.
I want to remind people, we had excellent testimony from Professor Chernow from Harvard. And he too, like David Cutler, indicated concern about future growth and came up with a very interesting model about what the state might do to slow it down in terms of creating some form of a cap. So I would encourage my fellow commissioners to take a look at Professor Chernow's testimony as we look forward. But ultimately, I need to remind us that we are operating under a statute where we have significant or strategic limits on what we can do. Are there any other questions or comments any other commissioners would like to make?
Stuart, this is Don.
Don, sure.
Yeah. First, I want to associate myself also with Marty Cohen and David Cutler's comments, both of which seem very, very important. To the point that Tim Foley made about Signature and Lawrence, yes, we may know that the 3.1% is not meant to apply to every single place, but they do have a case here. And somehow in our thinking, we need to be able to combine our awareness of variation in pricing with the psychology of this 3.1%. And I'd like to wrestle that to some point, because there are places that are getting paid less than they need, and there are places getting paid a lot more than they need. And although we're clear about the meaning of 3.1%, it may be that the field is not quite so clear. So anyway, I'll just leave that, Stuart. I will support 3.1% in the benchmark in this case.
Thank you, Don. But I do want to hark back to what David Seltz said. We are very mindful, and when we do the PIP analysis, and I've been part of all of them, we are very mindful of those institutions like Lawrence General that has had limited growth in revenues over a long period of time, as opposed to those who have had at or above the benchmark for several years. And I don't want to hide behind the statute, but I need to remind the group, as I said, the benchmark is an overarching one. And we will be mindful, as you pointed out, Don and Marty and others, about the need for certain institutions or certain kinds of services. And I know, Marty, you've reminded me, as Secretary Sutters has done several times, about the importance of overfunding of need to fund behavioral health. Okay, with that said, unless there's further questions.
Yeah, Stuart, this is Chris Kreider.
Oh, Chris, I am so sorry. I didn't see your name.
So I think I'm probably a bit of a black sheep here in that in a perfect HPC world, I would suggest to my fellow commissioners that we modify the benchmark. And I realize that won't happen, but I think 2020 has provided so much information for us. If there was ever a time to step back and reflect on the implications of accepting ever increasing costs, now is the time. We know we can't keep going at 3.x. Because if we do, healthcare costs will be well on their way to more than 20% of the Commonwealth's GDP. Yeah, and Stuart, I think you use the word strange for the experience 2020. I think it's strange indeed, but it was also deeply informative. And we're going to be seeing slides later in our meeting today that describe that. But fundamentally and nationally, it's clear that COVID has revealed the urgency for moving away from fee-for-service care, which is volume-based care, to more risk contracting, which drives value-based care. There have been small nibbles of value-based care payments in Massachusetts and everywhere else in the country over the past 6 or 8 years. And it looks like that is turning into a giant leap now as the industry becomes more competitive based on the cash flow problems that occurred by virtue of the pandemic in the second quarter of 2020, most dramatically. COVID also revealed widespread acceptance of telemedicine and remote monitoring capabilities. And these are, this is technology that has been lurking, but hasn't fit the business models until COVID. And now it has been accepted, and it is better and quicker and far less expensive because there is far less overhead involved if 50% of cognitive care can be provided remotely. And my surgical colleagues tell me that probably they see 25% going forward. Now, I understand that the rates have come back up to inpatient in office services, which is rather inconvenient for patients and very inconvenient for poor patients. So I just want to make the point that this is a unique moment in time. I wish that we could spent more time reflecting on it. And if, as I said, in a perfect world, I would vote to modify the benchmark, because this is the time I think healthcare costs could go negative, and quality could go up. And right now it's to the detriment of the consumers, taxpayers, and employers in Massachusetts and everywhere else that we continue to accept growth rates that describe a kind of a fixed marketplace rather than a dynamic marketplace. And I'd welcome, if I'm a complete black sheep here, I'm happy to be quiet, but I'm curious whether others see with the same intensity that I do things changing around the country.
So let me, Chris, let me associate myself with your comments. So let me make two comments. First of all, as Colleen indicated, this is the last year that we are legislatively restricted. So let us vote on we have to vote on the limits that we have. However, I'm going to task David Sells and the staff to bring back this issue during this year so we can have a full-blown discussion on what we should do going forward. There is unfortunately nothing we can do as long as we operate legally this year. So I'm not cutting you off, Chris, and I think you've gotten comments from several others in support in general, including me. So we will bring this up again and have a fuller discussion and have the staff prepare more detailed information, including looking at what Professor Chernow and others have done. But we need to vote now on whether we accept the 3-1, or in fact, the other option we face is actually to make it higher. So in the short run, given that we are legislative restricted, I'm going to ask Colleen to sort of have us take a vote on the benchmark.
Sure, I'll just read the motion so everyone knows what we're voting on and then ask for a nomination in a second. So the motion on the table is that pursuant to Mass General Law, Chapter 60, Section 9C, the Commission hereby establishes the healthcare cost growth benchmark for calendar year 2022 as 3.1%, subject to the further process set forth in the law. Is there a motion to approve?
So moved.
Okay.
And second.
Second. All right. Although now we have to do a roll call. We have to do a roll call, right, Colleen?
We do. I'll start with you, Mr. Chairman.
I approve 3.1.
Okay, Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Kreider.
Abstain.
Thank you. Commissioner Master Giovanni.
Aye.
Thank you. Commissioner Roeder
Aye.
and Undersecretary Peters.
Aye.
Thank you.
All right. Well, the motion is approved. We're now going to move on to a discussion of what has been transpiring in the marketplace. And I'm going to turn the program over to our Executive Director, David Sells.
Thank you, Mr. Chairman, and thank you, commissioners, for those comments and for the vote on the benchmark. And I will just note a preview for you that we are planning to, as one of our main agenda items at our next board meeting in May, to return to the performance improvement plan process and begin that review for this year with the new updated list of referred confidential entities from CHIA. So your comments around re-engaging in the performance improvement plan process are very well timed and will be a main topic for our next board meeting. I'm going to turn this over to Kate Scarborough Mills to discuss both kind of an update on some of our transaction notices that we've received, But to spend a few more minutes and time in today to present on two topics. The first of which is included in this agenda item around a recent transaction that we received notice for, which is the acquisition of Harrington Healthcare by UMass Healthcare. We're spending a few more minutes on this today because this is really an important transaction for Central Massachusetts. And given the evidence that hospital consolidation can lead to higher prices and spending, especially among consolidation of competitors, we really spent a great deal of time and focus during our preliminary review on this transaction, including working very closely with our economic consultants to really examine what we think the likely impacts of this transaction would be. So for the sake of public transparency and accountability for these market transactions, we're going to spend a few more times reviewing those findings and the decision to elect not to move forward with a full cost and market impact review. The second topic that we'll get to after that is on the Mass General Brigham determination of need applications, which I'll tee up after we get through this first section. So with that, Kate, I will turn it over to you. Thank you.
Great, thank you, David. So I will kick us off with our standard update on material change notice reviews. So as you see on this slide, we've received notice of 123 provider transactions since the process began in 2013, with formations of contracting entities, the most frequent, followed by physician and hospital mergers, acquisitions, and affiliations. On the next slide, you see that the HPC has 3 notices currently under review that are new since our last board meeting. First, a proposed joint venture between Shields Healthcare Group and Haywood Healthcare to own and operate a DPH licensed clinic for the provision of PET CT and MRI services to Haywood patients. Second, a proposal by Ophthalmic Consultants of Boston to acquire eye health services. Both organizations are privately owned subspecialty ophthalmic practices with locations throughout Eastern Massachusetts. And third, as we've discussed briefly in the past, because we knew this transaction was coming, a proposal by Collaborative Care Holdings, or CCH, which is a subsidiary of United Healthcare Group's Optum Care business, to acquire the non-clinical assets of Atrius Health. And I'll pause there in case there are any questions, but obviously those are still under review. Right. And then on the next slide, you see that since the last board meeting, we've also elected not to proceed to a cost and market impact review for 3 transactions, as you see listed here. First, a proposal by Mercy Medical Center to sell its Holyoke campus called Providence Behavioral Health Hospital to 3 limited liability companies, which plan to operate the facility under the name Mira Vista Behavioral Health. The purchasers are a group of affiliated, newly formed entities owned by individuals who currently operate the Terra Vista Behavioral Health Center in Devens. And the deal was crafted in close consultation with the Department of Mental Health. In our preliminary examination, we found that the transaction has the potential to increase access to behavioral health services in the region. Mira Vista plans to reopen 74 inpatient psychiatric beds, which were closed in June 2020, and to add 10 more beds over time and designate certain beds specifically for child and adolescent patients in addition to adults. Mira Vista also plans to continue all outpatient methadone and short stay services that have been provided at the campus by Mercy. And based on our analyses, we do not expect Mira Vista's commercial prices to exceed those of Mercy. And the scope of impact on the competitive market is similarly limited, given the low commercial payer mix of behavioral health services. The next transaction that you see summarized here, which we elected not to proceed to a cost and market impact review on, is the proposed acquisition by National Mentor Healthcare, a health and human services provider operating in 44 states, of 2 behavioral health provider organizations owned by Community Intervention Services, or CIS. Those 2 facilities being South Bay Community Services, which provides community-based behavioral health and LTSS services, as well as Futures Behavioral Therapy Center, which provides treatment to children and adolescents with autism spectrum disorders. And this proposed acquisition was the result of a Chapter 11 bankruptcy proceeding by CIS, in which Mentor was the court-approved purchaser. In our preliminary examination here, we found that the transaction would maintain access to these services, as Mentor intends to maintain all current South Bay and futures services without disruption. We also found a limited scope for spending increases due to the transaction, given that CIS's patients are primarily covered by Mass Health and other public payers for whom spending is not expected to change. And for the party's commercial business, Mentor is expected to assume South Bay and futures existing payer contracts. We did not review any evidence suggesting that the transaction is likely to negatively impact clinical quality. And finally, as David teed up, the proposed acquisition of Harrington Healthcare System by UMass Memorial Healthcare, which we will go over in the next few slides, and which I'll note is also currently under review by the state's Determination of Need program.
Kate, before we go on, back to the slide before, the just a clarification of that ophthalmology merger that
Yes.
So we're going to be looking at market concentration as a main issue there. Is that correct?
That's correct.
Okay, thank you.
Great. So on UMass and the acquisition of Harrington, as you know, we have 30 days from a completed notice of material change to determine whether a transaction is likely to have a significant impact on healthcare spending or market functioning. So that's really the key determination to determine whether or not something should move to a cost and market impact review. Even in that 30-day process, we can do a great deal of analytics. So we've summarized some here, but I will say there's a fair bit underlying all of this. So this first slide really just summarizes who the parties are. I think everybody is probably familiar with UMass, which is the largest healthcare system in Central Mass with an AMC, 2 community hospitals, and over 1,100 physicians. Harrington is a pretty small healthcare system in South Central Massachusetts, including a 119-bed hospital that predominantly serves public payer patients. So 85% of its inpatient discharges are public payer patients. And it has a physician network that already contracts through the UMass system with most commercial payers. Harrington Hospital and its physicians are also part of the UMass Medicare ACO, and UMass provides a number of clinical services to Harrington through a number of different existing clinical affiliations. Finally, I'll note that although the hospital itself has been doing okay financially, Harrington Healthcare System overall has faced some financial challenges in recent years, even predating COVID. On the next slide, you'll see what we found, a summary of some of our findings from our preliminary review. So we did find some scope for cost and market impacts, but also key mitigating factors. So first, we found that the transaction is anticipated to substantially increase inpatient market concentration in Harrington's primary service area. Largely due to the fact that Harrington is located in a more rural part of the state, there simply are fewer providers in this area. So accordingly, market concentration is already quite high here. And Harrington and UMass are 2 of the key providers for the patients living in this area. So a merger between them will accordingly increase market concentration by a fair bit. That said, there are some important mitigating factors that lead us to be somewhat less concerned than we normally would be about levels of concentration like those here. First, Harrington itself is quite small, and it has a quite small commercial payer mix on top of that. So its addition to the UMass system is just not likely to alter UMass's existing bargaining leverage with commercial payers by much. Second, it's important to remember that the physicians are by and large already contracting through the UMass system. So we aren't talking about any real change to the physician market. Finally, as you see in the orangish box at the bottom here, the same factors that lead UMass to have high market share in Harrington's service area also mean that it's a potentially promising partner for Harrington. If Harrington feels that it needs a partner to ensure that it can continue to provide important services to its patients over the long term, it may make sense for them to seek closer affiliation with a provider with whom they already have close clinical and contracting relationships. On the next slide, you see that we also looked at the existing price differentials between the parties to assess what spending impact would be there would be if Harrington were to receive the commercial prices of the existing UMass community hospitals. Here we found that for most commercial payers, for most services, Harrington is already paid at a similar or even somewhat higher rate than UMass's community hospitals. The one payer for whom there is a more substantial existing price differential is Fallon, which I will note is a major payer in central Massachusetts, but which has recently announced its plans to exit the commercial market entirely. So the scope and likelihood of a spending impact due to price increases is a bit unclear based on the existing price differentials. But combined with what I just said about the impact on bargaining leverage likely being small, we did not find that there's likely to be a significant increase in spending here. We also didn't find that there's likely to be a significant increase in spending or significant savings from shifts in site of care. The patients in Harrington service area already use Harrington at a relatively high rate. There's some chance that UMass could shift additional low acuity patients back to Harrington, which would achieve some savings, but the number of patients to be shifted is candidly likely to be pretty small. So the savings would similarly likely be pretty small. At the same time, there's the potential that additional patients could seek care at UMass over potentially other regional providers. That could potentially even be cost increasing. But here too, UMass is already being used at a relatively high rate for higher acuity services. So again, the shifts are likely to be small, not likely to be a major spending increase on that front either. On the next slide, you see that alongside the cost and market impacts, we also found that the parties' plans have the real potential to maintain and even enhance access. So this slide summarizes some of the significant commitments that UMass has made to Harrington in connection with the transaction. So for example, UMass committed to retain the vast majority of Harrington's services for at least 5 years, including medical, surgical, emergency department, imaging, cancer, laboratory, behavioral health, and substance use services. And certain services that are particularly important for ensuring ongoing community access, such as emergency, behavioral health, and substance use services, are actually eligible for an extended retention period of up to 8 years. UMass also committed to fund $42 million in capital expenditures at Harrington Memorial during the first 5 years following the transaction, and has committed to spending at least $4 million over 10 years in community investment funding to address social determinants of health in Harrington's service area. And I'll note that you see in the colored boxes up at the top of this slide, some of the other commitments that they've made in connection with the transaction as well. So the final slide here simply summarizes our findings. As I've laid out, the HPC ultimately found that the transaction was not likely to have a significant impact on healthcare spending or the competitive market, and at the same time has the potential to ensure continued access or even enhanced access for patients in Harrington's service area. And for those reasons, we've elected not to proceed to a cost of market impact review. But certainly with this transaction, as with other major transactions that have come before us, we do anticipate following the transaction over time, as well as its impacts. And I'll pause there in case there are any questions.
Oh, that was very helpful. Thank you, Kate. Are there any questions of the commissioners? If not, do we need a vote for you, for Kate?
No, this is our normal closeout process. We just elected to provide more background.
If not, why don't we move on? Because I know there's a lot more. Thank you. It was very good. Well done. Good staff work.
Great. So for our next agenda item, we wanted to provide you a brief overview of the determination of need or DON review process and HPC's role in that process as it relates to 3 large DON applications recently filed by Mass General Brigham, formerly Partners Healthcare. And I'll note that we provided some of this summary at the MOAT meeting back in February. So I apologize if any of this is review, but I will try to go pretty quickly through all of this. So as a reminder, providers are required to submit an application to the state's determination of need review program within the Department of Public Health before they can make specific changes in operations like major capital expenditures. So the DON program is charged with evaluating the application based on a number of factors laid out in its statute, including things like the project's alignment with the needs of its patients and its alignment with the Commonwealth's goals for cost containment. Now, most of the activities that require a DON do not require a material change notice unless they involve two unrelated providers. Generally, it would not come before the HPC. But that does not mean that we don't have a role in the process. So even where there's not a material change notice requirement, the determination of need regulations provide that the HPC is a party of record to determination of need filings. And that means that we get copies of everything that gets filed, all of the correspondence back and forth. And if there are any things like independent cost analyses, we get copies of those too. We also have the explicit authority to provide comments to the DON program at multiple different points during the review process, which we'll talk about more in a couple slides. So the Mass General Brigham DON applications propose three major interrelated projects. So first, there's a major expansion, renovation, and improvement of Mass General Hospital, including construction of a new building that will contain 482 new private beds with a corresponding closure of 388 existing semi-private beds. So that's a net new 94 beds at Mass General, as well as relocated and expanded outpatient oncology, 24 new operating rooms, 7 new advanced imaging units, which effectively doubles the number of PET CT and PET MR units to 4 and 2. The second application is the expansion, renovation, and improvement of Faulkner Hospital, which includes the construction of a 5-story addition to Faulkner with 78 additional med-surg beds, an 8-bed observation unit, relocated and expanded endoscopy services, and a new procedure room, a new MRI unit, as well as some shell space for future build-outs. And finally, there's the creation of 3 new ambulatory sites in Westboro, Westwood, and Woburn, with an additional site being proposed in Salem, New Hampshire, right over the Massachusetts border, but that is not subject to DON review in Massachusetts. Each of these sites is expected to include clinic space, an ambulatory surgery center, and advanced imaging, including a total of 5 new CT units, 5 new MRI units in Massachusetts. And in total, the projects require $2.3 billion in spending. So the HPC has been reviewing these very closely. I realize I went over that very quickly. I'll pause in case there are any questions high level about the DON process or these proposals before I go on with some key updates.
Thanks, Kate. Are there any questions or comments so far? We are going to get into more detail, but this is a good summary of what is being proposed. If not, Kate, why don't you move on?
Great. So since we provided an update to the MOAT committee on these applications in February, there have been a few key updates that you see summarized here. So first, the DON program allows any 10 taxpayers who have an interest in a given DON application to register as what's called a 10 taxpayer group. And that allows them to become a party of record to the application and have the ability to request hearings and offer comments. The timeline for creating these 10 taxpayer groups has now closed for the MGH and Faulkner expansions, but is still ongoing for a few more days for the 3 ambulatory projects. And a very large number of entities have registered, as you see here. To date, there are 10 for the MGH project, 6 for Faulkner, and 18 for the ambulatory projects, which is a much higher figure than we've seen in any of the past DON applications that we've reviewed. The department has also conducted public hearings at this point on each of the applications, and a very large number of entities have spoken out both in favor and against the applications, including MGB representatives, representatives of competing organizations, union members and leaders, politicians, representatives of civic organizations, and community members. And the written comment period is still open. So the ambulatory site proposal in particular is still receiving written comments. So the written comments have not all been received and posted yet. And then finally, on the next slide, you see that DPH has notified MGB that an independent cost analysis must be conducted for each of the 3 applications. So as a reminder, DPH has the discretion to require that an independent cost analysis, or ICA, be conducted at the expense of an applicant to demonstrate that a project is consistent with the Commonwealth's healthcare cost containment goals. And during the pendency of an independent cost analysis, the entire timeline for the review of the DON application is temporarily put on hold until the independent cost analysis is complete. Which really brings us to our last substantive slide, the next one. So as you may recall, the HPC has elected to provide comments to the DON program in the past, where it's determined that a project was likely to have a significant impact on healthcare spending and the competitive market, or I'm sorry, the healthcare market structure, and where the HPC has developed analyses that could support DPH in its review. And while the HPC has many potential opportunities to provide a comment to the DON program, in the past, we've elected to provide our comments to DPH after an ICA was provided. So if consistent with our past practices, we elect to provide a comment to DPH and do so after the ICAs are conducted, you see some of the benefits of doing that. Listed on this slide. It will give us adequate time to robustly analyze all potential aspects of MGB's plans that could impact the Commonwealth's efforts to meet its cost containment priorities and identify areas of potential concern. It could allow us to consider the methodologies and conclusions in the actual ICAs, while still allowing us to provide input to the DON program and staff for consideration well in advance of their staff report and final decision by the Public Health Council. But we wanted to really open that up for discussion and for your recommendations and feedback. So with that, I will turn it back over to the chairman.
Thank you very much, Kate. This was great. Now, I think we need to emphasize that this is a major expansion of the healthcare capacity, not only of Mass General Brigham, but also the whole state. It's also a provider that has a whole record, a good record of high quality, but high cost as well. In the future, we are going to get an opportunity to look at in detail the results of the studies, but I now welcome any comments or questions. So first, Don, would you like to lead us off?
Yeah, thank you, Stuart. Just the logic of this would suggest at the outset, subject to the ICA, that this will have substantial impacts on cost in the Commonwealth with a high increased supply of imaging and extra beds for our highest cost provider. So I'm approaching this really wanting some data. The question I have is about the independence of the independent cost analysis. And then I guess my real question is, it's a timing question. Can the HPC do its own cost analysis rather than just commenting on the ICA that it will be done? And if so, what would be the best timing for that? Because if we wait for the ICA to arrive, I assume the window for us to do an analysis would be shorter.
Okay, that's very good. Kate, you want to indicate what our plans are?
Sure. So I'll note that we have been, as I teed up at the beginning, we've been looking very closely at these applications since they were filed at the beginning of January. So we are working with the same teams of consultants and contractors and experts who we normally do for cost of market impact reviews. So regardless of the timing of when we actually offer comment, I'll say that we have already begun doing analyses and expect to continue to do those. So I'm not sure that the timing of the comment impacts our ability to conduct as rigorous a review as we possibly can of the potential impacts on healthcare spending in Massachusetts. And with regard to the question about the independence of the independent cost analysis, I will say that that is something that is within DPH's purview, and they are certainly our understanding is working hard to ensure the independence of that review process. But that is really something I can't speak to very directly because it is something really within DPH's wheelhouse.
And I'll just say on that the statute sort of contemplates that the ICA is conducted by a third party consultant that is, while it's paid for by the applicant, the party seeking the DON approval, it's not subject to their control. And that's how it's formulated in the regulation.
Thank you, Lois.
Follow-up question.
Don, do you have any follow-up with that discussion?
Yeah, thank you. This is really great, Kate, and thank you, Lois. So my question has to do with our line of sight, not the staff's, but the commission's line of sight as this develops. You say you've developed the materials and understanding. As commissioners, when do you think we're going to start to see some of the analyses and conclusions that you're drawing? Or are we going to get it all at the end when the ICA is finally provided? How involved could we be kept as you learn what you're learning?
That's a great question. So our goal will be to keep commissioners informed as we progress in our analytic work, similar to how we would do it in a cost and market impact review, where we try to brief commissioners as we go rather than leaving it all to the very end and just kind of giving you a finished report. So our goal is to keep you informed. I would say that to do the level of analytics around proposals that are as complex as these, it's not a process that can be turned around in a month. So we are certainly hard at work on those, but I would say that based on our past work on cost and market impact reviews, the analytic stage, it's hard to imagine a world in which the analytic stage is ever shorter than about 4 months. And certainly with the level of complexity proposed here, it could be a bit longer than that as well.
Thank you, Kate. My hope, just speaking for myself, is that we will be kept apprised of progress as you're going along, because we could perhaps be helpful looking over your shoulder. Thank you.
Don, that's very helpful. Patty, would you like to lean in?
Yeah, a couple of things that strike me much aligned with what Don had to say, but I'm concerned about the impact on the commercial market and the private payers with this type of broad expansion out to, I think it said Westboro, and sort of we in the commercial market or the employer market tend to think of the Mass General as being the downtown hospital, and people have to elect to go in there. But with this expansion of a high quality and high cost provider over an extended geographic area, I have concerns about the impact on commercial market there. And then my other is with other comment is with a different lens, and interestingly with the UMass Harrington proposal, it was shown there about investment in the community and investment in community outreach and equity issues. And I don't know if we, as an organization, as the HPC, can make a recommendation that any expansion of this type be tied to a commitment to an equity commitment, whether that's an equity program, dollars tied to community outreach for healthcare, anything of that nature. And I'm just sort of thinking out loud here, but if our mission when I came on board as part of the HPC was this equity lens, I think we have to build it into our policies as they move along. So that's just my comment.
And if I could just quickly respond, I will note that we are very much looking at these 3 projects with the equity lens as we're doing throughout all of the HPC's work. And so we are certainly trying to assess the impact on health equity of the plans as proposed. And important to note, the DON program does have the ability to impose conditions as part of an approval. Even if they do decide ultimately to approve a given application, they can attach a fair number of conditions.
Great, thank you.
Thank you, Kate. And Pat, let's see, Tim Foley.
Thank you. And thank you, Patty, for that comment. I was about to say something very similar, that particularly for these types of transactions, looking at the racial equity lens over it. And who benefits, who doesn't from this type of expansion. Just commenting directly to the outline that was given, Kate, was really helpful. And I agree. I think the timing makes sense that, as you laid out, to look at in a report or give comment post the ICA. I think that makes a tremendous amount of sense. Particularly, I think one thing that we've seen right over the last several years and reports is the growing number of outpatient services driving costs, but being driven by academic medical centers. That the shift of that there is really impacting the growth of costs in Massachusetts. So I think that's a clear indication this is something we need to take a close look at. And the timing of our report, as you laid out, makes a lot of sense to me after the ICA is done and before the DPH staff report is complete. I think the timing makes a lot of sense. And again, just reinforcing the importance of our analysis on with the health equity lens of this transaction and all other transactions that we look at going forward.
Thank you, Tim. So Marty, would you like to make some comments?
Just one comment in response to Patty's question. The DON process in Massachusetts requires a percentage of the investment through a percentage of the cost to be dedicated to a community investment.
Great, thank you.
Any other questions or comments? I want to make it clear to my fellow commissioners and to everyone else that this is, as I said, an important and major investment that they are going to be making. And we will have every opportunity to really analyze in detail the results of our studies as Kate and her team go forward. So this is only the beginning of what could be a quite extensive review. So if there are no further questions, we're going to move on to focus on a report and about the impact of the COVID-19 pandemic on the Massachusetts healthcare system. And I'm going to turn the program back over to David Selfs.
Thank you, Stuart. And just one final point on the previous topic. We will continue our work in analyzing the impact of those transactions, and we'll keep commissioners informed along the way as we prepare a comment for later this year in support of DPH and the DON review process. Shifting gears, we are really excited to be able to present our first batch of findings from our impact study of COVID-19 on the Massachusetts healthcare system, as shown on the next slide here. This is our interim report that was been developed over really the past 3 months as this mandate to study the impact of COVID-19 on the healthcare system was given to the Health Policy Commission on January 1st, as shown on the next slide, through the passage of the Putting Patients First Act, January 1st. And this legislation included a broad mandate for the Health Policy Commission to examine the effects of COVID-19 pandemic on the delivery system, including on the accessibility, quality, and cost of healthcare services, the financial position of healthcare entities, and the short and long-term implications of those effects on long-term policy considerations. So this is quite an ambitious charge with ambitious deadlines included within the legislative mandate in seeking results as soon as April 2021, with hopefully more results throughout the year, culminating in a final report next year. The mandate also includes a number of other additional components, as summarized at the bottom of this slide in the blue boxes, that go beyond just the impacts on accessibility, quality, and cost of service on topics such as impacts of closures of essential services, impact on the healthcare workforce, an analysis conducted with the Office of Health Equity at DPH on disparities in the Commonwealth. So a great deal of very important topics that the legislature charged the Health Policy Commission to examine and to release public findings to help inform policymaking moving forward. So we are here today in April 2021 with our first results of this mandate and this study. And I will note two important limitations for this first batch of results. One, I would note, as we all know, the availability of data for different types of healthcare providers and different health sectors is very variable in terms of both its timeliness and its depth. And so, unfortunately, we were limited in this very short-term turnaround of this mandate, and with available data to examine many areas that we think are worthy of examination, such as post-acute care, nursing home care, community health centers. These are entities that are critical to understanding the impact of COVID-19 on our healthcare system. But unfortunately, data limitations hindered our ability to be able to make new analysis point. The second limitation I would note is related, which is that the timeliness of this data is really limited to calendar year 2020. Most of the analyses we'll show include all of 2020, some only go through the end of September of 2020, and some include maybe the first month or two of 2021. But due to normal data lags in healthcare data, we're really looking at calendar year 2020 impacts in this first batch of results. And I think that's important to note because, as we all know, the pandemic is continuing, and we continue to have over 700 Massachusetts residents currently hospitalized for COVID-19. We have experienced a very significant winter surge in hospitalizations, and the peak of COVID hospitalizations in the winter surge actually occurred at the beginning of January. So we do not yet have data that really helps us provide insights into that second surge. And so we really are looking at a snapshot of some limited data sets in 2020. But with those limitations understood, we are so proud to have been able to really mine the data that we do have and to really provide here today for the first time publicly some brand new analyses that have not been made public or conducted anywhere else before around utilization trends and financial performance of the healthcare system in calendar year 2020. So the next slide really just lays out the outline of the chart pack that we have prepared. You can see that we have focused on utilization and market impact. The utilization trends, we do have information on a number of topics as shown on this slide. And on the market impact side, we do have financial information on both hospitals and health insurers for 2020. But really, want to emphasize again that there is much more work to be done here and more areas for examination. And I think our goal and intention is that we would come back to this board on a regular basis through these board meetings with additional components of analysis and examination when data and information becomes available to us for analysis. And so hope to have expansions on these and on other topics and other parts of the healthcare system as we continue this work throughout this calendar year. And as we go through these slides, really welcome from commissioners feedback and input about what additional areas of future study you would ask that the staff prioritize once we have that data and information available to us. So before I turn it over to Sarah Sadownik, who is our Deputy Director of Research and Cost Trends, to walk through some of our slides, I just want to say just a few words of acknowledgement. The development of this chart pack happened very rapidly over a very short time with data coming to us from our sister agencies, especially CHIA, the Division of Insurance, and the Group Insurance Commission, who prioritized giving us data as quickly as possible to allow us to be able to present information here today. So thank you to those other agencies. Also, a thank you and acknowledgement to Secretary Sutters and the COVID-19 Command Center for their input and assistance on this chart pack as well, and more broadly for their leadership throughout this year. As you will see in these slides, this is a reflection of a healthcare system that was under an incredible stress. And the leadership of the command center and Secretary Sutters was instrumental in making sure that the state weathered this storm and continued to provide access to necessary care for patients and protected the frontline workers. So thank you to her and everyone at the command center. And then also just a brief thank you to the research team at the HPC who have been working around the clock to be able to get these analyses ready for you here today. So with all of that introduction set aside, I am very happy to turn it over to Sarah, who is going to be showing a curated set of findings. They will seem like a lot of findings. I swear we did do some curation, and there is much more in the chart pack, which we will be posting later today. So with all of that, Sarah, please take us away. And we will stop along the way. There are a couple of breakpoints for kind of questions and discussions. But maybe I'll pause first and see if there are any broad questions or comments before diving into the results. Great. Hearing none. Sarah.
All right. Thanks, David, for that introduction and those acknowledgments. And I want to echo your acknowledgments of the work that went into this. That was a contribution from every member of the research team. And I want to particularly acknowledge Diana Sanchez, Leiden Marcelat, and Sasha Albert. Okay, so we're going to start this review with emergency department visits, starting with the public health orders on March 15th that halted non-emergent elective care. Emergency department visits dropped steeply, decreasing 55% between January of 2020 and April of 2020. While these visits did rebound quickly after the low in April, as of September 2020, the latest month of data we have available, they were still far below 2019 levels. In September, they were 24% below the September 2019 levels. And overall, I want to say that we took our mandate from the legislature for this report to report not only on looking back, how was the healthcare system impacted, but also with an eye to how do these trends inform health needs going forward and the healthcare system going forward. And with that framing, it's an important question for us as we continue our work that it's not clear that that this drop was, what are the many factors that contributed to that? The extent to which the factors where residents had less need of emergency services. Did they need services but were avoiding necessary care, or did they find alternatives to the emergency room, relying more on the primary care system as we might hope. Okay, so to further start to address those questions, we looked at changes in the type of emergency department visit. The line at the bottom is the trend in emergency department visits for COVID-19, and then we see of course the trends in April and May, and we see steep declines in contrast in visits, emergency department visits for reasons related to injuries, steep declines in potentially avoidable visits, and a small decline in behavioral health, but not to the extent of the others. So potentially avoidable visits decreased 60%, in April 2020 compared to April 2019. And when we're talking about potentially avoidable visits, we can't say whether any one individual case that might have been appropriate, but we're talking about the types of things that where emergency department is not, sort of the optimal site of care. This can be related to dental pain. This can be related to ear infections. This could be, at the kind of most avoidable end, even sort of a bad sunburn. So that line for potentially avoidable reflects all different types of visits where either care could have been was not sort of an immediate need, or whether there was immediate need, but that visit could have been performed in a non-emergency department setting. Okay, so we looked at how potentially avoidable visits varied by age and found a really striking trend for children that the percentage of visits that are potentially avoidable decreased most for children compared to other age groups. And while and that's that gold line that you can see. And while there is a clear seasonal effect to trends in these visits, as you can see the dips in 2019, the decrease in 2020 from January to September was much larger than the change in the comparable months in 2019. Okay, so mental health, or I should say, I'm sorry, behavioral health visits, which include mental health and substance use related visits, had the smallest decline in March and in over this time period. It's again unclear what was driving that decrease, if that's again patients not seeking care, if there were barriers to access, if there was improvements in access due to telehealth services, or other ability to seek care in alternative settings. So as we're about to show, while the total number of visits did decline, in fact, a greater proportion of those visits resulted in ED boarding. And to share the detail on those results, I'm going to turn to my colleague, Laura Nasuti.
Thanks, Sarah. Yeah, next slide. Thank you. As part of this work, we wanted to highlight behavioral health ED boarding. This topic has come up several times since the pandemic started in both board and committee meetings, as well as in news reports. But these slides are our first opportunity to present on data related to behavioral health boarding. For this work, we examined emergency department visits where the primary diagnosis was behavioral health. We then looked at how much time each patient spent in the emergency department. And if they spent 12 or more hours in the emergency department, we considered that behavioral health boarding. As a side note, other state agencies and research use varying time points to determine ED boarding. But again, for this work, we're talking about 12 hours. Although this report focuses on the impact of COVID on the healthcare system, from this graph, we can see that in 2019, about 27% of behavioral health related ED visits resulted in boarding. And as Sarah mentioned, even though the total volume of behavioral health ED visits decreased in 2020 compared to 2019, the percent of these visits that resulted in ED boarding actually increased to an average of 29%, with, as of September, 31% of those visits in September resulting in ED boarding. From January through September, about 28,000 behavioral health related ED visits were boarding visits. One thing that is necessary to highlight here is the changing inpatient psychiatric bed capacity over this time period. Next slide. And I'll talk about that a little bit more with this slide. This slide shows percentage of behavioral health ED visits resulting in boarding by HPC region from March through September 2020. As you can see, there is considerable variation in ED boarding by region. The darker orange represents more boarding, while the lighter orange, you see less behavioral health emergency department boarding. Again, some of this increased rate of boarding may have to do with the loss of psychiatric bed capacity. There has been a loss of beds due to closures, such as Trinity's Providence Behavioral Health Hospital in the early summer of 2020. There has been environmental factors, such as the flooding that caused Norwood Hospital to close this spring. And on top of these specific examples, there has also been a reduction in beds to allow for COVID-related distancing and quarantine space. In testimony to the legislature last October, Health and Human Services estimated a loss of nearly 270 inpatient psychiatric beds. There are currently efforts underway to increase these beds in new and existing facilities. One of the aims of the Executive Office of Health and Human Services roadmap for behavioral health reform is to increase inpatient bed capacity, as well as increase community-based alternatives to the emergency department for urgent behavioral health care. Next slide. And finally, in regards to behavioral health ED boarding, we did a deeper dive by age group and found that the percentage of patients boarding varied with age, with almost 40% of pediatric behavioral health patients experiencing ED boarding compared to 28% of adults. Again, even though there are fewer overall behavioral health ED visits, the percent of visits that resulted in boarding increased. Additionally, pediatric patients were more likely to experience boarding that lasted over 48 hours. Over 800 pediatric patients waited for 48 hours or more in an emergency department. And like Sarah previously mentioned, what we don't know about these dips is whether or not this was care avoidance or lack of need. I think we hope to explore that more as we get more data sources in. And now Sarah will talk more about our hospital inpatient findings.
We have some questions.
Unless there were questions. Yep.
Commissioner Blakeney?
Yeah.
Actually, thank you. I believe my question was answered, but my concern was the difference of the disparity between adolescents and adults in every aspect of behavioral health. And I believe I heard you say that adolescents tended to be boarded a bit longer than adults. Is that correct?
Yes, when we looked at length of boarding, they were also on average being boarded for longer.
And did that ultimately result in a placement, or were they discharged? Or do you know?
I think I need to go back and look at this. So for
okay,
this,
thank you.
Yeah, I can go back and get that information.
That's great. Great, thank you very much.
This is the end of the emergency department section. So welcome any other questions on the potentially avoidable and behavioral health related ED visits, if any.
Why don't you move on, David, and then we can come back to it.
Okay.
Okay, so now turning to inpatient care, again, we see that after March 15th, care dropped sharply with inpatient volume dropping 31% from January to April, with a low in April of almost 42,000 patients, but that includes in April the admissions for COVID, which is just a little over 8,000 admissions. So in April, those 8,000 COVID patients represented about 20% of all admissions that month. So actually, I'm going to turn to the next slide. So while the number of admissions dropped, the intensity of patient care and the hospital resources needed to address that care increased sharply. So we can see for April, total number of admissions dropped 25%, while the volume of ICU days increased 63% in that month compared to the previous April. So we see that those trends changed as the course of the pandemic changed throughout 2020. And by November of 2020, hospital admissions were still 4% below what they were in the previous November, but ICU days has in fact returned by November to the same volume as the previous November. Okay, so we looked at trends in admissions by type of hospital admission, and we see that we see in the orange line the cases for COVID, and then we see large drops in care from sort of all types of care. Oh. Sorry, I don't know why that happened. Is it Hannah? I don't know if you're on this. Can you? Okay, great. Sorry for the technical difficulties here. Okay, so hospital admissions that stemmed from the ED declined sharply, as well as scheduled admissions in that light blue line. So we see again that behavioral health admissions did have a relatively small decline in April, and then sort of picked back up to a steady line. So the trends in behavioral health can be a little hard to interpret why it looks like care was relatively steady when we hear from so many sources about the the great increases in behavioral health needs. And it's important in looking at this data to keep in mind that this is acute care hospitals only. It doesn't include admissions at freestanding psychiatric hospitals. And again, as Laura mentioned earlier, during this period, also the overall loss of psychiatric bed capacity is an important factor to keep in mind. So capacity was not only fixed, but decreasing. Next slide, please. Okay, so can you go back one? Okay, sorry. Well, sorry about this. Let's move to the next one. Okay, so so this slide shows the change in admissions by hospital cohort, and as well as that's the difference in the navy blue bars, as well as the share of all discharges in 2020 represented by COVID patients. That's the orange component. So what we see is that all hospital cohorts treated a fairly similar percentage of COVID patients throughout 2020. However, community high public payer hospitals had the largest volume of COVID patients, since they have the highest overall volume, and also that they lost the most volume in other types of inpatient stays, a 15% decrease in non-COVID inpatient stays compared to the lowest difference of 11% lower among teaching hospitals. Next slide. Okay, so now we're turning to the patients during this time period. And what we found is that patients of color represented a disproportionate share of COVID-19 related hospital admissions in 2020. We broke this data into age cohorts because it's important to account for age when you look at these numbers, because we know that COVID patients are disproportionately older, and older patients in Massachusetts are disproportionately white given the demographics in Massachusetts. So when you break it into age cohorts, the picture starts to become a little more clear. What we found, again, is a disproportionate impact among patients of color, and particularly Hispanic and Black patients. Among patients age 65, we found that Black patients represented twice the share of all COVID-19 admissions compared to their share of total admissions. That's the orange bars versus the blue bars. In Asian American populations over age 65, the share of COVID admissions was 65% higher than their share of all admissions. And then among both younger and older Hispanic patients, we found that the share of COVID-19 hospitalizations was twice their share of all hospitalizations. So this data is very striking, and also well-timed. The CDC just issued on Monday a national analysis of this same question, and similarly found racial and ethnic disparities in COVID hospitalizations across the US, with the proportion highest for Hispanic patients across all US regions. The factors that are driving these results demand attention, namely that people of color are more likely to have higher risk of exposure due to employment and housing conditions, as well as a higher risk for severe disease due to social determinants of health, such as access to nutritious food and environmental factors, among others. Next slide, please. So we also looked at differences by income, and found that patients from lower income communities represented a disproportionate share of COVID-19 hospitalizations in 2020 as well. This graph shows for patients 18 plus, the difference again in share of COVID-19 admissions in the orange, and the share of all admissions in the blue by community income quintiles. So this is based on the patient zip code, the median household income in that zip code, not the patient's personal income. So based on their community. So we found that the disparity was largest for patients who lived in the lowest income quintile in the state. That's household income less than $59,000, and found that of those patients, share of all COVID admission, that they represented 31% of all COVID admissions versus 25% of all admissions. In contrast, the highest income quintile, representing 12% of COVID admissions versus about 15% of all admissions. Next slide, please. So the next section is going to talk about hospital financials. But before we get there, we have one slide that we wanted to be sure to show on telehealth. This is a very important topic, and one that we look forward to getting richer data on and tracking closely. So this data is from our partners, the Division of Insurance, for fully insured, commercially insured patients in Massachusetts from January to September, and this is preliminary data. So what this data shows is that across for both, so this graph shows the percent of all visits that were performed through telehealth for behavioral health visits in the blue line, primary care office visits in the orange line, and specialist visits in the gold line. The use of telehealth really, just was widely used in September and represented about 70% of all visits of these types for all types of care here. However, in the spring and summer, the proportion of primary care and specialist visits that were provided through telehealth decreased and really shifted back to in-person care. So by September, about 20 to 30% of those visits were performed through telehealth. In contrast, the use of telehealth and behavioral health really remained strong throughout 2020. Only dipping slightly and shifting back slightly to in-person care after April, so that by September, about 66% of all behavioral health visits were performed through telehealth for commercial patients. Next slide, please. So now we'll talk about hospital and health system financial impact. And I want to call out that this data is from the Center for Health Information and Analysis and provided in more detail in their recently published report on their website. So this graph shows the change in median margin by hospital cohorts from fiscal year 2018 through fiscal year 2020. I want to first just sort of say the reminder that, of course, fiscal year 2020 only goes through the three calendar quarters of 2020. So the last 3 months are still are not reflected here. But what we found is that total margins were positive for all hospital cohorts in the fiscal year. Including the COVID relief funding from federal and state sources. Next slide. Okay, so this shows by hospital cohort in fiscal year 2020 what the margins were, including and not including the state and federal COVID-19 relief funds. And what we see is that with the relief funds, all cohorts had positive median margins, but without those funds, the median margins would have been negative for all cohorts. That also goes for the statewide margin, median margin of 3.1% versus without the relief funds would have been a negative 4.2%. So while all cohorts benefited, community hospitals and community high public payer hospitals would have been particularly hard hit financially without the relief funds, those 2 points on the far right. Next slide. Okay, so this slide shows, now pools all hospitals together and shows by quarter revenue from different sources compared to total expenses. What we see is that when we look at quarter 3, the segments here are net patient service revenue, revenue from treating patients directly in that navy, other sort of direct operating revenue in the orange, and then federal and state COVID-19 relief funds in the gold and light blue. So we see that in quarter 3, the relief funding prevented far greater losses, comparing that gray bar to the blue and orange. But by quarter 4, sort of regular revenue was only slightly below expenses. So total revenue was near expenses even without the COVID funding. It is, again, an important point that it's uncertain whether that financial improvement would continue through the rest of 2020, given the fall resurgence of COVID-19 hospitalizations. However, we know that in Q4, patient volume really had been returning, and so this may provide a positive indication of a financial picture moving forward. Next slide. So we've talked about margins for cohorts on average. And here we see that those averages were masking a really huge variation by individual hospital, where some had negative margins, and in some cases substantially negative margins, even with the COVID relief funding, while other hospitals had positive margins, and in some cases even substantial positive margins. So we see the total margin is in the blue bars. The margin without the relief funding is in the orange data points. That's for 2020, of course, and then the gray bars compare those 2020 results to that same hospital's margin in FY19. So we saw that fewer hospitals were profitable in fiscal year 2020. Of 49 hospitals included in the data here, 9 hospitals, or about 18%, were not profitable in 2019, those gray bars, compared to in fiscal year 2020, over a third of hospitals were not profitable. So of the hospitals that were not profitable in 2020, we found that they were disproportionately community hospitals and community high public payer hospitals. And I think, in summary, particularly for hospitals that typically have lower negative margins year over year, uncertainty about future relief funds and about what post-pandemic care patterns look like is a particular concern. Next slide. So this slide shows financial performance for healthcare systems. And we found that fewer healthcare systems had positive margins in 2020 than in fiscal year 2019. Again, even with the COVID-19 relief funding preventing greater losses. So of the 22 health systems depicted here, 14 had positive margins in 2020 compared to 19 in 2019. And overall, without the relief funds, only 3 health systems would have had positive margins in 2020. So I think these figures really give a sense of how much benefit the relief funding provided. Next slide. So we want to conclude the hospital and health system financial section with talking about prices. This is the growth. This is in the U.S. overall, the growth in average prices for each, by January of each year. And so we see that hospital and physician services prices grew dramatically in 2020, with average hospital commercial prices growing from 2.3% in 2020 to 5.7% in 2021. And as we continue to consider lessons from the pandemic for financial sustainability, including financial models for providers, prices are an important part of the story to balance financial sustainability for providers with affordability as the economy and households begin to recover. And I think that's a good segue to the next slide on insurer financials. So this slide shows is a very simplified metric of financial performance, comparing premium revenue, the excess of premium revenue over medical expenses on a per member per month basis. The bars on the left, average Blue Cross Blue Shield, Harvard Pilgrim, and Tufts. The bars on the left are other Massachusetts-based providers for in the commercial market. They include Always, Health New England, and Fallon Community Health Plan. So we see among the big three a large increase from $37 average per member per month in 2019 to $49 in 2020, and a even larger jump among other Massachusetts payers in recent years. So a few important qualifiers for this information is that this doesn't necessarily indicate profit. It does not account for other income or other expenses such as administrative expenses. And this is really a preliminary picture, since we know that based on the sense that this data gives, these aren't adjusted for rebates that insurers will likely have to provide in 2021. It's sort of differences of this magnitude give a sense that that insurers will very likely be providing rebates. And in fact, nationally, sort of national data came out this week on that sort of on average in the U.S. Rebates for 2021 were the second highest they've ever been. Rebates for 2020 were the highest. 2021 projected to be the second highest. So again, this is a very preliminary picture as we move forward. Next slide. Okay, and finally, the last two slides that we'll present are about the impact on enrollment. We see throughout 2020 that coverage continues to shift from commercial coverage to mass health in response to economic instability and federal coverage policies for Medicaid, for mass health. In particular, that mass health was tied to a higher matching rate. There were federal requirements to maintain eligibility for patients, even after those individuals may have reported changes that would normally shift them to Health Connector or other commercial coverage. So we see the increase from March 2020 to December 2020 of 13% for mass health, compared to a decrease of 3% for commercially insured members. Next slide, please. So this slide takes a closer look at what was happening in the commercial market. And the story is really different based on the type of coverage or the type of employer. So even though we saw an overall very large decline on the last slide, what we see for large employers, the largest employers in that green line, is that actually enrollment was pretty stable throughout 2020. In contrast, where we see the biggest changes, the biggest declines, are in the small group market in the blue line, as well as the gold line, which is the label is large group employers fully insured, but we think that's really referring to medium-sized employers. Sort of in contrast, we see an increase in coverage through the connector, both subsidized and unsubsidized, in the navy and orange lines, which continued through most of 2020 with changes in the fall, probably reflecting both shifts to change the decrease in subsidized care, reflecting shifts both to mass health and to unsubsidized care through the connector. So, I think these trends really, they tie closely to what's happening in the employer market, and they show important implications as the Commonwealth continues with long-term recovery. So, that's the last data slide that we'll show. If you want to move to the next slide. So the following slides just summarize our key findings, going through inpatient hospitals, inpatient hospital data. Next slide. Emergency department use, potentially avoidable and financial behavioral health findings, and then telehealth and insurer financial impact. So I'll stop there and welcome any questions on this large amount of material that we've provided.
Sarah, thank you so much. Wow, you sure provided a lot of information. I want to thank you and the staff that put this together, because I know how hard it is to put all this stuff together. So thank you. And we will now entertain questions or comments by the commissioners. So please let us know. Anybody want to? David Cutler, please.
Yes, thank you, Sarah and Laura, so much. Can I just start with a factual question, which is, if we think of inpatient care as the most expensive part of medical care, so institutionalized care, by what % is that down in 2020 in total?
What? I'm sorry. What percent?
How much below what you would have guessed is institutionalization in 2020 relative to what one would have guessed? Like if you just add over all the post-COVID time. Is it down 10% in total, 15%?
I'm not sure. If David Auerbach is on the, oh, yes. There you are. If you have a sense of that.
Well, I think what you're asking is right there on the slide. You see the last sentence of the key findings in inpatient admissions, that total admissions were down 9%.
9%, got it.
Mm-hmm.
So that suggests we're looking at something like a 9% reduction in spending. Well, I guess the inpatient, if the inpatient care is most of it, we're looking at somewhere between 5 and 10% reduction in spending for 2020 relative to 2019. Right. So I want to tie this back to our earlier discussion. If all that care came back, then we'd expect, which it seems to me there's no way it would be, but if it all came back, then we'd expect the growth rate in 2021 over 2020 to be something like 5%. Although actually, I'm sort of thinking about, I guess you'd go back to the normal, so you'd get the let's say 5 to 10% up, and then you get the other 5 to 10% that you missed. So that would be a huge increase. But then to come to our earlier discussion, if we said, okay, for this year, the growth is 3% over the previous year, we'd still be far below that, right? So we'd still be below where we were in 2019 if we did that. So that would be getting at what Commissioner Kreider was getting at, which is, could we get an actual reduction here? The answer is yes, given what we saw, if there's no give back of that, we would be getting an actual reduction.
Could I ask follow before to Sarah or David Auerbach? A number of the slides stop in September. Now, when you talk about a reduction of 9%, is that including all of 2020? Or does it stop in September where a lot of the information you have?
The inpatient admissions is full year 2020. The time frame does change based on different analyses.
Right, because there was a slide where you talked about 4 quarters, but you really only had 3 quarters for 2020.
Financial data is 3 quarters of the year for 2020. And that's the same for the ED analyses. The inpatient volume analyses are the full year.
Because the numbers that I've seen for the country is that spending is down by the end of the year, only about a little over 1%. So now it may have gone down more in Massachusetts, but it seemed like spending had come back almost to the benchmark or to the baseline.
That does seem surprising given what we have here, because there's no way this is down just 1%.
Well,
so we must be down more than the nation.
I just don't know. I'm confused on some of these numbers. Now, this is just inpatient admissions. If you look at outpatient, and then because what I was talking about was total spending and not just inpatient, and the total spending for the country was, I'm just doing it from my mind, was I think by the end of the 2020, about a little over 1%.
We have data that's not presented here, but is in the full report that we have, looking at fully insured commercial, the set of fully insured commercial Massachusetts-based payers. Total medical expenses were down 2% for full year 2020.
It's also important
That's
to note
consistent with what I said, yeah.
Mm-hmm. And that the prices went up in a lot of areas. So even if your drop in inpatient admissions is 9%, increases in prices will make the total spending drop not be as much as 9%.
I see. I see. Yes. So the utilization is down about, say, 5 to 10.
Exactly. Yeah. So I think we
But
need
the prices are.
That's
4
exact.
roughly.
Yeah.
3 to 4.
Total. I was talking about total spending.
No,
So
I see
be careful.
I see the point. So that's much less. That's a much less remarkable fact.
That's right.
Yeah.
That's why I don't want you, by being presented with all of these semi pieces, since we're focusing on total spending. And what's happened, it sounds to me like, is that the providers are making up for the reduced utilization by jacking up prices.
I would also note the second key finding here too, which is that the acuity of the patients being served was higher, which can lead to higher reimbursement for those patients as well.
Are there other questions or comments people want to make? Again, I want to emphasize this is an interim report, and that more information is coming available daily, right, David? And we will have an opportunity to see all the information, including the write-ups in the future.
That's absolutely correct, Chair Altman. This was, as I said at the beginning, our first batch with the data that we had available. And so looking forward to updating with more recent data as that becomes available, getting that full picture of not only what happened in 2020, but into the first quarter of 2021 as this pandemic continues will be important, both on utilization and on financials. And then finally, we're also, as you said, Stuart, we're kind of picking at the underlying components that all add up to total spending, but really hope to be able to have that total spending information that includes areas that are not examined here, such as home health care, ambulatory care, outpatient care, prescription drug care, which may have, we suspect, different utilization trends during this time period as well. So not the full painting or the full picture. Nonetheless, think this is additive to the conversation in terms of providing transparency about what we do know in 2020.
Don, you want to jump in?
Yeah, quick question. First, just again, this is the best I've seen anywhere in the country. It's remarkable work, and I hope the staff feel as proud as I know they should. At the entity level analyses of losses and gains with or without the relief funds, just could you comment, Sarah, on the apples to apples question? Are entities calculating that the same way, do you think? Is there a solid way to look at margins, or is that something we should have a little bit less confidence in at the entity level?
It's a good question, and I think it's one that's hard to. I think it's one that's hard for us to answer. Given that there's a lot of the entity level includes different provider types with different financial performance, and there's just that's so it's hard to it's hard for us to say. I think it's a good question and one that we can explore more with our partners at CHIA.
Yeah, I mean, I guess analytically, it's like, well, ones that were seemed able to maintain margin, how did they do that? Or is it a accounting issue, an accounting issue where it's actually a little hard to drill to that level? Just a thought, and you're very busy, but if you had.
Yeah. I will just add to that. Thank you, Commissioner. Certainly when we're looking at health system financials and comparing health systems, these are complicated organizational structures with many different component pieces. Hospitals are for the most part of broader health systems that include physician organizations. And so sometimes even looking at the hospital margin won't tell you the full picture about the financial health of the entire system. And so I will give a note of credit to the Center for Health Information Analysis that has revamped some of their financial reporting to try to be a little bit more rigorous in the definitions of people reporting. And that is something that we are also going to be adopting into some of our data collection sources as well. So some thought, but obviously it gets quite complicated when you're talking about big, complicated organizations with many component pieces and corporations almost. So thank you.
So again, we are going to be looking at the final. And again, we'll have a better feel for the whole year as we get complete data for 2020. For those of you who are interested, I would refer you to a very good study that was done by the Commonwealth Fund, which also looked at utilization for the country and provided data for the whole 2020 period. And I hope, David Sells, at the end of the day, we can compare again what we're seeing in Massachusetts with what is happening around the country and whether we're consistent or we have some deviations. But we will look forward to that. So again, more to follow.
All right, Mr. Chairman, Commissioner Kreider has a final comment.
Okay, very good.
Yeah.
Thank you, Colleen.
Thanks, Colleen and Stuart. I think Don Berwick hit on an interesting question to try to understand the data quality here and the consistency of the data quality. Some hospitals stand out high and low, and I'd encourage the staff to dig into some selected cases so we can understand those trees in this vast forest and get an answer to the question of whether we're looking at apples to apples data, or we can pick up on some performance issues that or management success or lack of success. So sometimes the data can really hide some of the questions that we should be asking. So I hope that either anecdotally or otherwise the staff can get some of that additional information. The other thing that I would ask of CHIA is to do a little bit of ad hoc analysis. We have spent time over the years looking at low value procedures, and that data may be incomplete, although it's, 2020 is now 3.5 months ago. So the claims data is certainly in on low value procedures, and it'd be interesting to see what happened to those items, those selected surgical procedures and imaging tests and so on. We've got a pretty good list of them during 2020. It might provide insight into 21 and beyond.
I would like to weigh in to both the comments by Don and Chris. I've done some analysis in previous years. When you're dealing with these big not-for-profits, their ability to put things in different categories, I think, Chris, you were alluding to this. I mean, you could eliminate all what we might think of as margins or profits by including more costs. And so that's why when we look sometimes at, we're better off looking at total spending or total expenditures per admission adjusted, and not try to parse it out by how much was profits or margins, because of the ability of organizations to manipulate the data under it and show whatever they want. So your comments are well taken. Unfortunately, the ability of our staff to go beneath is very limited, because ultimately we are left with reviewing what is available, but they will try, I'm sure. Okay, any other final comments or questions? If not, we're going to move on to the last portion of our meeting, and I'm going to turn the program over again to David Sells.
Great. Thank you, Chair Altman, and thank you for the feedback and input on the COVID study. Looking forward to continuing that work. So we're going to shift gears now and talk a little bit about a grant program that was legislatively mandated for us to administer. And we went through our competitive process for selecting awardees and are here to announce the good news of who we hope to select for this program. So I am going to quickly turn it over to Commissioner Blakeney for a little bit more of an introduction here.
Thank you very much, David, and thank you for this opportunity. This is a wonderful program that we're involved in, and it's an opportunity to take a look at the subject of substance abuse and exposed babies. It's a serious issue. I think we all know that. It's also an incredibly challenging clinical issue to get to the bottom of and to find consistently good outcomes. The science is still very broad. The science is still testing out lots of different opportunities. And I think that this program is going to help in small measure to be able to continue to pursue what makes the best sense over time and what makes the best sense to help both mothers and babies, not just one at the expense of the other. So with that, I'd like to turn it over to our very capable staff, who I know are incredibly excited about the potential for these programs.
Thank you so much, Commissioner Blakeney. Can we go to the next slide, please? So good afternoon, commissioners. I am here today to make recommendations for your consideration for the cost-effective coordinated care for caregivers and substance-exposed newborns, otherwise known as C4SEN investment program. So with C4SEN, we are building on our history of investments in this space. And as Commissioner Blakeney mentioned, a lot of learning that has come along with it. With that perspective, we have developed this particular investment program with the goal of supporting innovative care models that promote collaboration among primary care and specialty providers, behavioral health providers, community-based organizations, and social service agencies to ensure high quality, efficient, and culturally sensitive care, both for substance-exposed newborns and, as Commissioner Blakeney so rightly pointed out, their caregivers during their period of highest risk. So for those of you who have recall seeing this slide before and have powerful properties of recollection, you'll see two differences here. When we initially designed this program, we were working with total funding of $1.2 million, 300,000 of which, as David mentioned, came via legislative mandate. And our goal was to fund 4 awards. After seeing the interest in the program and considering the strength of applications, we decided to contribute an additional $300,000, bringing the total funding amount to $1.5 million and increasing the maximum number of awards to 5. Other than that, all other aspects of the program were unchanged. Next slide, please. In reviewing these applications, we considered the core program features listed here, as well as selection factors related to applicant, program operations and budget, sustainability and impact, and health equity. Next slide, please. So in total, we received 9 applications representing a range of organizations, many of whom, as you can see here, had prior history with HPC investment programs. And just at this moment, I want to pause and really thank and acknowledge all of the applicants. I mean, the proposals were incredibly strong and interesting. And, it's always a challenge when these programs are oversubscribed, and just the quality of the proposals made for a particularly difficult review and selection. And I say that difficult in a good way. I'd also like to acknowledge that we could not have gotten through this difficult review and selection process without incredible work from our review and selection committee, including my colleagues, Wendy Nicholas and Molly Sass, who really kept us on track and got us to this place. So thank you to both. So with that, I'd like to share our recommendations for the 5 awards, which together total just under $1.5 million. Next slide, please. So as you can see, we are recommending funding for 5 organizations: Bay State Franklin Medical Center, Berkshire Medical Center, Mercy Medical Center, South Coast Health, and South Shore Hospital. So I'd love to do just a very brief deep dive into each one of these so you have a sense of the work that we will be supporting. Next slide, please. So beginning with Bay State, their objective is to build on their existing Moms Do Care program and create a new interdisciplinary clinic to optimize interactions between providers, family, and early intervention providers, and also to fill what they perceive as some gaps in service. The kinds of things that they intend to fund with this investment are new part-time program coordinators, social workers, training costs, and stipends to ensure that EI, and I should be clear, early intervention providers remain fully engaged in the program. Their goal is to enroll at least 20 new caregivers per year. Next slide, please. Meanwhile, in the Berkshires at Berkshire Medical Center, Berkshire hopes to create what they've called the Berkshire Connections program to provide individualized care coordination to caregivers beginning in pregnancy, and then coordinate with their Berkshire OBGYN practices and local pediatric practices to ensure that care and support continues postpartum. Berkshire's a little bit unique among these programs in that it is starting, it's starting earlier. It's in an earlier phase of development. And that's why the target enrollment is actually higher than some others, because they're building up from scratch. And their hope is to use C4SEND funds to fund a full-time program director, to provide technology for telemedicine portals, which is particularly important and valuable in rural communities, travel costs, and again, stipends for pediatric pediatric partners to help them set up their information sharing and data collection practices. Next slide, please. At Mercy Medical Center, they're taking a slightly different approach. Their intention is to use C4CEN funding to basically add the technology architecture to promote new clinical pathways and a care coordination model to streamline the provision of services among an existing network of providers. So essentially, they want to build the interstitial sort of connections among a range of providers with the idea that patients entering their program from any point in the care continuum receive a consistent and supportive approach to care. They too will increase the use of telemedicine among geographically distant sites. They're going to fund some staff time to operationalize the new system and also provide some practical support to patients in the form of funds for transportation and other much needed resources. Next slide, please. At South Coast, the C4CEN investment program will help to expand their existing New Beginnings program for substance-exposed newborns and their families with the addition of what they're calling the New Beginnings Community Outreach Project. So essentially taking what's largely been a hospital-focused program and extending it well into the postpartum period consistent with our requirements. Their goal is to use funds to facilitate communication among providers and community agencies and really support cross-system collaboration. To do that, they'll be funding a new community outreach specialist, some additional services of an RN care coordinator, and ultimately to also provide some assistance for caregivers to attend clinical visits and community appointments. And their goal is to add an additional 25 new caregivers per year. And finally, next slide, please. We have South Shore Hospital. Their objective is also to expand on an existing inpatient program provided through what they call SHORE, which is embedded in their perinatal behavioral health program. Using C4CEN funds, they will introduce a peer support role to help with postnatal care. They will introduce perinatal and pediatric care coordination to ensure that the substance-exposed newborns continue to have access to supportive services. They'll introduce lactation consulting and also introduce some data analysis with the goal, all with the goal of doubling their service capacity. And they too hope to increase enrollment by 25 to 35 caregivers per year. So with that, let me pause and see if there are any questions or comments from commissioners.
Thank you, Kelly. I know how hard you guys have worked to put this together, but I'm really impressed by the five that you've selected. So let me turn it over and ask any questions or comments from my commissioners. If not, we need to vote on approving these five awardees. So I'm going to turn the voting over to Colleen.
Okay, great. Is there a motion?
So moved.
All
And a
right,
second.
second to the motion.
Second.
All right.
All right, we'll start with you, Mr. Chairman.
I'm all in favor. Thank you.
Thank you. Vice Chair Cohen,
Yes.
Commissioner Blakeney,
Aye.
Commissioner Cutler,
Aye.
Commissioner Haupt,
Aye.
Commissioner Kreider,
Yes.
Commissioner Master Giovanni,
Aye.
Commissioner Roeder,
Aye.
and Undersecretary Peters.
Aye.
Thank you.
Thank you all. First, I want to really thank David and Colleen and the staff. I pushed them very hard to make sure that we had adequate time to discuss the issues as well. And I want to thank them for paring down much of the of the presentations. I want to make it clear to both the other commissioners and to the public at large that the full complement of all the slides are available on our website. I'm going to, and I want to make it clear that this presentation has been taped and is available again through our website, including a video recording of the meeting on YouTube. Now I'm going to turn it over to David to remind us of our upcoming meetings.
Thank you, Stuart, and thank you, commissioners, for a really great meeting today, and for all of the helpful input and feedback along the way. We do have an upcoming board meeting that actually is not reflected on this slide, and I'm hopeful that Colleen can remind me the exact date of our next board meeting.
Is it May 19th, is that right?
It is May 19th. You're absolutely right. Thank you, Commissioner. So May 19th, we will be back again as a group for our next board meeting, and look forward at that time to, as I mentioned earlier, coming back to the performance improvement plan review process as one of our main agenda items. So thank you all. And Stuart, I think we can close out this meeting.
Well, thank you so much. So I now will entertain a motion to adjourn.
Motion to adjourn.
Okay, a second.
Second.
All right, all in favor? Aye.
Aye.
Again, thank you all for attending